We will be continuing from the page number 89 from Therapeutic Guidelines, Salivary Gland Infections. Diagnosing salivary gland infections, swelling of a parotid, submandibular or sublingual salivary gland may indicate salivary gland infection. However, a non-infective cause of swelling, example salivary gland obstruction, is more likely. So non-infective causes are much more likely than the causes which are infectious in nature. Box 11, page 90 outlines potential causes of salivary gland swelling, which we'll be seeing in the next page. Benign mesenteric hypertrophy, lymphadenopathy, or acute spreading odontogenic infections may be mistaken for salivary gland swelling. So one is related to masseter, one is the lymph node swelling per se, lymphadenopathy, or acute odontogenic infections also may be mistaken for, these are some of the differential diagnoses for salivary gland swelling. Investigations or imaging, example ultrasound or computed tomography, may be necessary to determine the diagnosis. Then we have acute suppurative sialadenitis, including parotitis. Acute suppurative sialadenitis or including parotitis is usually caused by Staph aureus, though occasionally it is polymicrobial in adults. The glands are enlarged, often hot and tense, and pus may be expressed from the gland duct. The patient is usually systemically unwell, dehydrated, and has difficulty swallowing. So this microorganism parotitis, or which is also known as acute suppurative sialadenitis, you have to remember Staph aureus, because on basis of this we will remember it's antimicrobial. Now glands in this case will be enlarged, often hot and tense, and pus may be expressed from the gland duct. The patient is usually systemically unwell. The patient would be dehydrated and has difficulty swallowing. Management of acute suppurative sialadenitis includes urgent referral to hospital for surgical review, rehydration. Again, the patient health deteriorates because of dehydration primarily. Culture and susceptibility testing of blood samples, though we can start empirical antibiotic therapy on the basis of Staph aureus. If the swelling is fluctuant, intraductal or surgical drainage, then send pus for culture and susceptibility testing. Antibiotic therapy given intravenously initially, then orally when the patient can swallow. If Staph aureus is identified in blood culture, treat as S. aureus bacteremia. If the results of blood culture indicate polymicrobial bacteremia, we would need to seek expert advice. So what are the potential causes, this whole table of salivary gland swellings? What are the different causes which can result in it? First is inflammatory causes. So acute bacterial infection, acute suppurative sialadenitis, caused by Staph aureus, streptococci, or mixed anaerobes. This is first inflammatory cause. Then viral infections, which include mumps, Coxsackie virus infection, Epstein-Barr virus infection, chronic infections, which include tuberculosis, actinomycosis, autoimmune disease, which includes Sjogren's syndrome. Then we have obstructive causes, stones, sialadenitis, trauma, mucus retention, ranula. These three are the obstructive causes. Then we have metabolic causes, which include obesity, hypothyroidism, alcoholic liver disease, malnutrition, example, eating disorder. Then we have tumors, which could be benign pleomorphic adenoma, malignant mucoepidermoid carcinoma, adenocystic carcinoma, adenocarcinoma, or lymphoma. So we have a mnemonic which can be made for salivary gland, this salivary gland swelling, which is, okay, last is drug or food hypersensitivity. The most commonest are IOMT, but Internet of Things you would have heard. So IoT from there, and metabolic causes and drug or food hypersensitivity would be very less, but we can remember IoT and MD separately. Okay. In Indian language, there is a word called moti, okay, which means obese. So I remembered it from that, which covers metabolic causes, obstructive diseases, inflammatory causes, and then I for inflammatory. This is one extra. Then we have intravenous antibiotic therapy for acute suppurative sialadenitis. We have to start the initial empirical antibiotic therapy in conjunction with local intervention or drainage, and this is flucloxacin 2 gram. You would not find this antibiotic in non-salivary gland diseases, and flucloxacin is exclusively in this therapeutic guidelines is read in salivary gland infection. So child 50 milligram per kg up to 2 grams, same like amoxicillin, intravenously 6 hourly. Switch to oral therapy once the patient can swallow, like they are doing for every other bacterial disease. For patients with risk factors for methicillin-resistant Staph aureus MRSA infection, we would see the risk factors of infection of MRSA. And we would use, in this cases, methicillin-resistant ones, we would use vancomycin, okay, intravenously. In some region, based on local community-acquired MRSA susceptibility patterns, clindamycin or lincomycin is a suitable alternative to vancomycin. So it's based on the local community-acquired susceptibility. So clindamycin is better, or lincomycin, both 600 milligram dosage, IV 8 hourly, IV 8 hourly. For patients with immediate non-severe or delayed non-severe hypersensitivity, we would use sensitivity to penicillins, we would use cefazolin 2 gram, 8 hourly. So the first line of therapy, flucloxacillin. If MRSA resistant, vancomycin intravenously, but we can also in some regions go for clindamycin, lincomycin, or if hypersensitive to penicillin, cefazolin. And for the patients with immediate severe or delayed severe hypersensitivity, we would use clindamycin or lincomycin as above. I have never seen any other, guidelines telling so precisely about this is the first line, this is the second line, and this is allergy. So this is the best resource, not just for ADC exam preparation, for otherwise also to know which antibiotic to prescribe in what circumstance. Oral continuation therapy for acute suppurative sialadenitis. So after the patient is able to swallow, we can switch from IV to oral. If the results of culture and susceptibility testing are available, modify oral therapy accordingly. If not available, we are giving dicloxacillin 500 milligram, 6 hourly for a total of 10 days, or flucloxacillin, the same which we gave IV, for 500 milligram orally, 6 hourly for 10 days. It is intravenous plus oral, here also intravenous plus oral. So this is, it goes for 10 days of this therapy. Then for patients with risk factors for MRSA infection, ETG for whom results susceptibility in testing are not available, you would use trimethoprim and sulfamethoxazole, 160 milligram plus 800 milligram. The combination trimethoprim 160, sulfamethoxazole 800, or clindamycin 450 milligram orally, 8 hourly for a total of 10 days. Then for patients with immediate non-severe or delayed non-severe hypersensitivity to penicillins and without risk factors for MRSA, use cephalexin 500 milligram orally, 6 hourly. For patients with immediate severe or delayed severe hypersensitivity to penicillins and without risk factors for MRSA, use trimethoprim and sulfamethoxazole or clindamycin as above. So some dosages of antibiotics in there for salivary gland infections. But must remember the first line, which is IV, which is flucloxacillin. Okay, that is the first line of a drug, which would be far more important to remember. And oral continuation therapy, dicloxacillin or flucloxacillin 500 milligram for 10 days. It is to be given 6 hourly. Then any doubts so far? So we begin with oral mucosal disease from therapeutic guidelines, continuing from page number 93. Assessment of oral mucosal disease. Now it will involve all the oral mucosal diseases from candidiasis to pemphigus to lichen planus, everything. Oral mucosal lesions are common. They can be due to physiological changes, local disease, or oral manifestation of a skin condition, an adverse drug reaction, or a systemic disease. So, see, it could be variety of conditions, physiological, any local disease happening like trauma or burn happening in the cheek region, oral manifestation of a skin condition, maybe a pemphigus, or adverse drug reaction, which is leading to some blisters or ulcers or rashes inside the mucosal lining, systemic disease like GIT, giving oral manifestations. Successful management of an oral mucosal disease requires an accurate diagnosis. Assessing an oral mucosal lesion involves taking a full patient history, including medication history, performing a thorough extraoral and intraoral examination, and using diagnostic investigations where appropriate. Have a high index of suspicion for oral cancer, for risk factors for oral cancer. If any red flag features are present, the diagnosis is not clear, or the patient has not responded to initial treatment, early referral to appropriate specialist is required. So first thing is take full patient history, then including the medication and thorough extraoral and intraoral examination. And we would need investigations where needed, where it is red flag lesions. That is mostly we would need biopsy in most of the cases. And we would go through the red flag table now. Wherever the diagnosis is not clear or the patient has not responded to treatment, very early referral to appropriate specialist is required. It's star marked, and they have written failure to respond to initial treatment, unclear diagnosis, presence of any suspicious features could indicate malignancy. What are the red flag features of the oral mucosal disease? Oral ulcers that have lasted more than 2 weeks. Okay. Any ulcer long-standing, which is more than 2 weeks, if the patient says he doesn't remember since when is this ulcer there, that means it is pretty long, more than 2 weeks, and must be tested. Oral ulcers that recur. And one should rule out aphthous ulcers. Okay. Then we have non-traumatic oral ulcers in children. Pigmented lesions on the oral mucosa. Red, white, or mixed red and white lesions on the oral mucosa of unknown origin, or with features of potentially malignant disease such as induration, ulceration with rolled margins, fixation to underlying tissues, lesions in high-risk sites like lateral tongue, floor of the mouth. So all these are signaling malignancy. Hardened ulcers, hardened area with rolled margins whenever it is, fixation to the underlying tissues, and lesions at high-risk sites, which are lateral tongue and floor of the mouth. Then facial or oral paresthesia. What happens in mostly cancerous lesions or malignancies, there would be lack of pain. The innervation is dying and it leads to paresthesia more than the pain. So that's why the patient delays seeing the dentist, because it's just not paining. They neglect that lesion. Persistent oral mucosal discomfort with no obvious cause. So a discomfort which is lying, which is long with no obvious cause. Lumps or swellings including lymphadenopathy. We have the cancer staging, right? T1N1, M0, T1N2, M0. So if lymph nodes are involved, local ipsilateral lymph nodes or bilateral lymph nodes get involved, that is, the cancer has spread through the lymphatic route, involve the lymph nodes. Swelling, pain, or blockage of the salivary gland, suggestive of salivary gland disease. Suspected allergy or adverse reaction to dental materials. Example, oral lichenoid lesion. Then dry mouth that is not adequately relieved with artificial salivary products and non-pharmacological methods. So again, it must be investigated, which is not adequately relieved once. Then dry mouth caused by systemic disease. Suspected oral manifestations of systemic disease like syphilis, Beckett syndrome, HIV, inflammatory bowel disease, lichen planus, and pemphigoid. Then lesions occurring in immunocompromised patients, example, patients with neutropenia or HIV infection. This is an important chart, red flag features of oral mucosal disease. I find it, this chart, along with the reading of the lesions, is far more important, because they can test you with the condition of pigmented lesions were present on oral mucosa, and the answer would indicate you would send for biopsy to the specialist. Some oral mucosal diseases are associated with significant morbidity and mortality, particularly oral potentially malignant disorders and oral cancer. Oral potentially malignant disorders include oral leukoplakia, oral erythroplakia, candidiasis, chronic hyperplastic candidiasis, actinic cheilitis, lichen planus, OSMF, oral submucous fibrosis, discoid lupus erythematosus, dyskeratosis congenita, and epidermolysis bullosa. So we would go through these lesions. Most of the lesions are covered in ODEL textbook through cases. So apart from reading from here, we would go through these significant cases from ODEL. Then Oral potentially malignant disorders can become malignant at the site of the lesion, but also predict an increased risk of cancer at other sites in the mouth, even in clinically normal appearing oral mucosa. The following conditions can be managed in general practice, provided there are no red flag features present that would warrant referral. So these conditions are well manageable. They are not very red flag features if there are not there. If no red flag features, they can be managed in general practice. What are these conditions? Aphthous ulcerative disease. So aphthous ulcers can be managed. Traumatic oral ulcers, very well managed. Candidiasis, angular cheilitis, oral herpes simplex virus lesions, dry mouth, oral mucositis, just the inflammation of mucosa, amalgam tattoo, geographic tongue, and hairy tongue. There are physiological causes of oral mucosal discolorations, which are fordyces spots, which are ectopic sebaceous glands, which is seen in the buccal mucosa usually, and leukoedema, which do not require active management. So these are the ones which we would read about these lesions in the forthcoming pages. And now they are going to oral cancer. Oral cancer is associated with significant morbidity and mortality. Early presentations of oral cancer are usually asymptomatic. That's why one needs to be very cautious about identifying the red flag features and referring for biopsy. Whereas late presentations include pain, discomfort, reduced mobility of the tongue, because it gets fixed to the structures underlying. If it is on tongue, it would get fixed and expand within the muscular tissue of the tongue. Increased mobility of the teeth, if it's in the bone, or inability to wear dentures. Oral cancer varies in appearance and can mimic many other oral mucosal diseases. Oral cancer can mimic many other oral mucosal diseases, so early specialist referral is required for investigation and biopsy of any suspicious lesion. So any lesion basically more than 2 weeks, which the history is not clear, the cause is unclear, it's good to refer for biopsy, at least even if it is say OSMF, even if it is say lichen planus. Let it come as a diagnosis as those particular lesions. Any suspicious lesion needs early specialist referral for investigation and biopsy. Then we have squamous cell carcinoma is the most common oral cancer or oral malignancy, which arises from epithelium of the oral cavity. Now we have the mucosa is, the standard mucosa is epithelium and below is the connective tissue. So carcinoma arises from the epithelium. Oral squamous cell carcinoma can affect any part of the oral mucosa. However, it is most commonly on the lateral surfaces of the tongue, floor of the mouth, or the gingivae. In that too, lateral surface of the tongue and floor of the mouth are more common. That's why these sites are mentioned in the high risk table. Risk factors for oral carcinoma include advanced age, male gender, smoking or tobacco use. It could be smokeless tobacco, betel quid, or these things. Alcohol use, it compounds effect of tobacco. If both are done together, it's a concomitant or synergistic action. Infection by oncogenic viruses. Human papilloma virus is a risk factor for oral carcinoma. Personal or family history of squamous cell carcinoma. So one needs to ask history of oral mucosal diseases in the family also, if you suspect any lesion in the patient's mouth, and history of cancer therapy. The treating specialist should perform the biopsy of an oral mucosal lesion. In rural or remote areas where a delay in specialist review is expected, seek expert advice on biopsy technique. A punch biopsy is not appropriate. Okay, so the specialist should perform biopsy. Our job is as a general dentist is to refer for biopsy for oral mucosal lesions. But in rural or remote areas where there would be a delay is expected, the dentist present in the rural center can do the biopsy by taking expert advice on biopsy from the expert. And punch biopsy is not appropriate. One has to take a proper biopsy, which is the healthy tissue along with the abnormal tissue. Then this is some of the pictures of oral squamous cell carcinoma on the left ventral surface of the tongue. Other risk factors are prolonged immunosuppression, areca nut or betel nut chewing. I'm not coloring this. The color itself is a bit gray. So prolonged immunosuppression, betel quid chewing. Betel quid is separate from tobacco here. So it's a different risk factor they have counted. Genetic susceptibility, environment, occupation, and diet may also contribute to the development of oral squamous cell carcinoma. Cancers originating from salivary glands and supporting non-epithelial tissues are less common than squamous cell carcinoma. Metastatic cancers to the oral soft tissues and jaw bones commonly originate from primary malignancies in the breast, prostate, kidneys, or lungs. Leukemia and lymphoma may also present in the oral cavity. This is another picture of squamous cell carcinoma on the ventral surface of the tongue. This is left mandibular alveolus. See, eventually it ruptures. It creates gory looking surfaces presentations. At these stages, it becomes painful or produces burning sensation or discomfort. Then moving on to other lesions. We would read about this more in detail from oral case. Then oral leukoplakia. Leukoplakia is a clinical term for non-removable white lesion that is not easily recognizable as any particular condition and therefore requires further investigation. So it's a very important point. That's not, it's a kind of a diagnosis of exclusion. It is not lichen planus, it is not white lesion, it is not any other, it is not OSMF. We have ruled out traumatic ulcer or anything which could be present as a white lesion, non-removable, it is non-scrapable like candidiasis. So when we cannot ascertain any particular condition to it and it's still existing, it is then a clinical term for leukoplakia. And when it needs further investigation. Then oral leukoplakia may be homogeneous, uniform lesion often with a fissured surface, or non-homogeneous with surface irregularity and textural or colored variation, which is speckled. Some oral leukoplakia lesions show histologic evidence of dysplasia, carcinoma in situ, or invasive squamous cell carcinoma. So it's a precancerous lesion. So if changes in the cells happen inside, it can create dysplasia. Carcinoma in situ means in situation that carcinoma has developed. Pre-existing lesion has produced that carcinoma, or invasive squamous cell carcinoma. We would have already read about oral cancer previously. The malignant transformation rate for oral leukoplakia is variably reported, but it's 0.13 to massive 34%, with a mean annual transformation rate of 3.8% per year, means 4 in 100 people almost will, in them, it will convert to oral cancer. Refer patients with oral leukoplakia to appropriate specialists for biopsy and monitoring. Biopsy of persistent, undiagnosed oral white patch is required to exclude epithelial dysplasia, carcinoma in situ, and squamous cell carcinoma. Okay. This is the leukoplakia on the ventral surface of the tongue and floor of the mouth. Here, everywhere, they would have written the same line about the biopsy. Then comes the next term, oral erythroplakia. Like leukoplakia is a white lesion, erythroplakia is a clinical term for potentially malignant, fiery red lesion that cannot be attributed to any particular condition. Lesions are asymptomatic, isolated, commonly appear on floor of the mouth, tongue, soft palate, and buccal mucosa. Lesions may appear as smooth, velvety, granular, or nodular plaques, often with clear margins. Oral erythroplakia most commonly affects middle-aged and elderly men. Approximately 70 to 90% of oral erythroplakia lesions are carcinoma in situ or squamous cell carcinoma upon presentation. Urgent referral to a specialist for biopsy of oral erythroplakia lesions is essential because its transformation rate is 70 to 90% carcinoma in situ or squamous cell carcinoma upon presentation. So it's much more disastrous. There it was approximately maximum was 34% and began from 13 to 34 with 4% per year. Here, the minimum range is 70 to 90. Periodic review and repeated biopsy by managing specialist is recommended for all patients with oral erythroplakia because malignant transformation is common in them. This is the erythroplakia of right posterolateral surface of the tongue. Then we have human papilloma virus-related oral lesions. HPV can cause wide range of oral mucosal lesions. It is transmitted by direct contact with a lesion. That's why very important nowadays the gloves are like prerequisite. Previously, the old age dentists used to do examinations and without gloves, bare hands. It was far more commoner at that time. So squamous papilloma is the most common oral HPV lesion, appearing as a protruding growth with a small finger-like projections. Sexually transmitted HPV infections can cause oral HPV lesions called condyloma acuminata. Verruca vulgaris common wart is also caused by HPV infection and may present in the oral cavity, a small wart within the cavity. Both condyloma acuminata and verrucola vulgaris can be clinically similar to squamous papilloma. Papilloma has like finger-like projections when you check microscopically. Oncogenic types of HPV are now recognized as cause of squamous cell carcinoma, particularly of the posterior tongue, tonsillar region, and oropharynx. So posterior parts of the tongue, tonsils, oropharynx are affected with HPV type of squamous cell carcinomas. They appear to be distinct entities separate to the oral cancers associated with alcohol and tobacco use. So, refer patients with suspected HPV lesions to an appropriate specialist for biopsy and management. So specialist referral is actually needed for biopsy here too. This is how the papilloma looks, finger-like, wart-like appearance. And next lesion is oral lichen planus. We would resume this in the next session on oral lichen planus onwards.